Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Changes in Clinical Context for Kaposi Sarcoma and Non-Hodgkin Lymphoma Among HIV-Infected People in the United States, by Yanik et al. My name is Richard Little, and I am head of the Hematologic and HIV Malignancies Therapeutics section at the Cancer Therapy Evaluation Program of the National Cancer Institute in Bethesda, Maryland. My oncologic specialty is hematologic cancers, particularly those associated with HIV infection. This interesting manuscript reports that a greater proportion of individuals with AIDS-related Kaposi sarcoma are diagnosed in patients on effective HIV therapy, whereas for non-Hodgkin lymphoma, the proportion of cases on HIV therapy has not changed over time. From 1996 to 2011, the burden of cases occurring in the later years have distinctly higher CD4 T-cell counts compared to the earlier years. The authors rightly point out this is cause for concern and suggest as tumors develop at higher CD4 counts, the tumors may have to escape immune surveillance, and this would make them more aggressive. They note a prior epidemiologic report that suggested when lymphoma is diagnosed after initiation of HIV therapy, there seems to be a negative impact on outcome. The findings reported in the paper are remarkable in part because this group's prior work has shown that with effective HIV therapy, the deadliest complications of AIDS, the opportunistic infections and AIDS-defining cancers, have substantially decreased in incidence and are becoming rare as the cause of death in HIV-infected persons. They have shown that as the risk of historical AIDS complications decreases, the risk of cancers more commonly seen in the background population, non-AIDS defining cancers such as lung cancer and Hodgkin lymphoma, are increasing. What I mean by AIDS defining and non-AIDS defining requires us to recall that in the early days of the epidemic, AIDS was diagnosed on the basis of certain infectious and cancer complications. Development of Kaposi sarcoma, primary central nervous system lymphoma, and other aggressive non-Hodgkin lymphomas occurring in previously healthy younger individuals was a striking departure from the known epidemiology of these diseases at that time in history. Thus, Kaposi sarcoma and aggressive B-cell non-Hodgkin lymphomas became AIDS indicator conditions and are referred to as AIDS-defining cancers. Other cancer types occurring among HIV-infected persons are called non-AIDS defining cancers. When potent triple-drug combination antiretroviral therapy was introduced in 1997, HIV therapeutics was transformed and the modern era of HIV medicine began. The combination cocktail, as it came to be called, was found to frequently result in regression of Kaposi sarcoma, and the incidence of KS and lymphoma plummeted. Primary central nervous system has become distinctly rare in HIV disease. Moreover, the clinical approach to the HIV-related aggressive lymphomas was overhauled. Prior to effective HIV therapy, low-dose lymphoma therapy was administered in a way to avoid infectious complications but without expectation of prolonging life beyond 6 to 18 months. Burkitt lymphoma was treated similarly and most often not cured. In the era of modern HIV therapeutics, therapy for non-Hodgkin lymphoma is specific to the lymphoma type and is given with curative intent. Autologous bone marrow transplantation in relapsed disease is considered a standard of care. Outcomes appear equivalent to the background population. Given these features of cancer and HIV in the modern era, how are we to interpret the findings by Yanik and colleagues? The study population was obtained from 8 HIV clinics and represents a population cohort relatively healthy on HIV therapy. It follows that whenever complications seen related to HIV in this population will most likely then be seen in those on HIV therapy with an ever-increasing proportion who have suppressed HIV viral loads and higher CD4 T cells. It is already well established that complete HIV suppression with high CD4 T cells reduces but does not eliminate risk of HIV disease complications. Also, it is important to understand that the focus is on the proportion of cases, not absolute incidence. What about the author's suggestion that KS and non-Hodgkin lymphoma occurring in well-treated HIV status could be biologically distinct from tumors occurring at low CD4 T cell counts, thus potentially requiring different therapy? Well, this is an established finding in B-cell non-Hodgkin lymphomas, but perhaps less so in Kaposi sarcoma. Epidemiologic patterns have shown that comparing cases in the pre-HIV therapy era to the modern era, dramatic shifts have occurred over time as fewer people on HIV therapy have advanced CD4 depletion. Thus, lymphomas occurring at low CD4 T cell counts are not often seen. As the risk population shifts to those with high CD4 cells, there is an epidemiologic shift in lymphoma types. Instead of the often fatal primary brain lymphoma being frequently seen in the past, one now sees proportionally more highly curable tumors such as Burkitt lymphoma. Also, instead of the poor prognostic ABC-type diffuse large B-cell lymphoma, the proportion of more favorable GCB-type DLBCL is seen. Missing from Yanik and colleagues' paper are the diffuse large B-cell lymphoma subtypes, limiting the ability to expand on the tumor biology CD4 cell relationship. Claims that poor outcomes are seen in patients diagnosed with lymphoma while they're on HIV therapy raises concerns about patterns of care as much as it does about underlying tumor biology. I would shift the author's question from one of tumor biological differences that may require alternative therapy approaches to one that emphasizes the ability to administer optimal therapy in an otherwise healthy patient. KS tumor biology may not necessarily be altered in setting of high CD4 cells. This tumor is caused by the human herpes virus 8, also known as KSHV. Ongoing HIV-related inflammatory factors create risk for cancer and heart disease even with HIV suppressed below standard detection limits and at high CD4 cells. Also, risk of KS is related to specific presence or absence of viral epitopes directed against the human herpes virus 8. HIV-negative patients missing these epitopes are at similar risk of KS as those who are HIV positive. Incomplete immune reconstitution can allow opportunistic disease like KS to develop even when the CD4 cells are in the normal range. This interesting paper is a testament to decades of research in HIV and its complications. KS and AIDS-related lymphomas have been transformed from certain pre-terminal AIDS events into chronically manageable for KS, in the case of lymphoma often curable. The fact that cancers are being diagnosed when patients are on good HIV therapy with high CD4 counts and low viral loads is encouraging news for the clinical oncologist. This means that one can approach patients with HIV and cancer as any other patient. A major caveat: beware of drug-drug interaction. For example, protease inhibitors given with standard ABVD chemotherapy for classical Hodgkin lymphoma results in excessive toxicity and undermines curative potential. I usually recommend changing patients off of protease inhibitors to the newer integrase inhibitors in order to avoid or reduce this concern. Be sure to speak with the infectious disease specialist, and with a team approach, cancer outcomes, regardless of what the cancer is, in persons living with HIV can be equivalent to those in the background population. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.